Shall we start?
Sure.
Good evening and welcome everyone for another fortnightly event of our Young Family Physicians Forum. It gives me great pleasure to extend a warm greeting to our dear Madam, Consultant Family Physician Dr. Lalanta Senaratne, who has been a constant source of strength to all of us throughout these years. So allow me to introduce our very own Dr. Prabhath Nanayakkara, a second-year family medicine registrar, to impart knowledge on a very intriguing topic today. The warmest color is blue. Over to you, Dr. Prabhath.
Thank you very much, Dr. Arindra, for those kind words of introduction. Good evening, everyone. I would like to welcome Madam Lalanta Senaratne and all the registrars and medical officers who are joining this forum. Today, I present an interesting case of patient with headache. The reason I have chosen the topic, the warmest color blue, I would like to keep a mystery yet, but at the end you will realize why. And my patient is Mrs. S, who is a 29-year-old mother of one child, one kindergarten child, and presented to the OPD with headache for 4 months. So her headache was there on most of the days. There was no specific time. Some days she wakes up with headache. Some days it comes in the evening. And severity is like 7 to 8 in the pain scale. And she could not concentrate. She was suffering a lot due to this headache. And she has taken treatment from many physicians, but many general practitioners. But it was not relieved. Okay. And so listening to this part of the history, can you tell me what are the differential diagnoses you have for this headache? Hello?
Tension headache.
Sorry.
Tension headache.
Yeah, it's look like a tension headache. Most of the time it was band like, but there was no specific area or laterality to the headache. Yes, what else? Okay, at that point, actually, I couldn't realize what it was. It's like an atypical headache, but this atypical headache is an exclusion. So we have to know a bit about how we analyze the symptom of headache. So for that, we have to differentiate whether it's a primary or secondary headache, and also we have to exclude red flags. I think about 2 weeks back, we had a very descriptive discussion about headache by Dr. Manoj, who is my co-registrar. And how descriptive his discussion was, like when I talk about Snoop 4 here, he talked about Snoop 10. There were 10 P's. So actually you can access that lecture in our YouTube channel, college YouTube channel, and get more knowledge about red flags. And it may be a primary or secondary headache. Usually primary headaches are benign and recurring, and there's no relationship to underlying cause. Whereas secondary headaches may be sudden onset, very painful, and commonly due to some underlying cause. So there are well-known 3 primary headache disorders: migraine, tension headache, and the cluster headaches. So when we take migraine, it's like it occurs in females more than males. And as this picture shows, it's usually unilateral and has a pulsating quality, moderate to severe pain intensity. And there may be associated nausea and vomiting. And they have photophobia and phonophobia. Some may have aura and some may have no aura. So migraine headaches may last from 4 to 72 hours. And when we consider tension headaches, it's like the opposite. Even though it's also common in females, usually tension headache is bilateral or band-like, and it's pressing or tightening in quality, not like the non-pulsatile quality of the not like the pulsating quality of migraines. And it's not very severe like migraine. It's ranging from mild to moderate, and it's not aggravated by physical activity or other stressors as in migraine triggering factors. There is no nausea, vomiting, photophobia, or phonophobia. So the cluster headaches are very severe and unilateral. The site is usually orbital or supraorbital and temporal. So there may be associated conjunctival injection, nasal congestion, eyelid edema, or forehead and facial sweating, meiosis plus or minus ptosis, and even a sense of restlessness or agitation. So these are the 3 primary headaches, and there are other primary headache disorders also, which are classified in International Classification of Headache Disorders. And there are secondary causes of headache, like sinusitis, common things, preferred pain from dental, cervicogenic cord, temporomandibular dysfunction, dehydration, caffeine, or analgesic overuse headache, refractive errors, or somatization. These are, even though we don't consider much, these are the common things we encounter with headache patients. And we should not forget things like tumor, AV malformations, or subdural hemorrhage, or meningitis as red flags. So when we brainstorm more, I thought, is this headache the ticket of entry for this patient regarding any other different problem? Or is it a masquerade? The famous Bible of Martha describes 7 masquerades: diabetes, depression, thyroid and endocrine diseases, drugs, anemia, spinal dysfunction, and UTI. So headache and depression are common associations. Depression-associated headaches are non-pulsatile. They may be prolonged or even may be described as lifelong. And they have a quality like tension headaches, dull, generalized, may not have a definite pattern or location, and may not fit to either primary or secondary headache. So after inquiring more into Mrs. S's history, I couldn't fit her history into one of the primary or secondary headaches, other causes. So therefore, I asked about the depression. Mrs. S was feeling sad most of the day, and she gets angry even with her 5-year-old son. And she had a disturbed sleep and especially wakes up early in the morning. Her husband was taking alcohol more frequently for the last 4 months. And she did not like the habit even before. And she specifically mentioned this last 4 months thing. And she said she had a poor relationship with her husband. So when we put this into the depression diagnostic criteria, she had most of it, about 7 out of 9. and she had moderate depression, that is more than 5 features with moderate functional impairment. So I took this queue of 4 months and inquired deeper. And I asked what happened 4 months ago. She said she had a suicidal attempt. She had drank a pesticide, vomited, and admitted to the hospital. Thereafter treated in the psychiatric clinic. She was treated with antidepressants. And she was not okay with these antidepressants because they caused sleepiness. And she wanted to cook for her husband. She wanted to cook the morning meal for her husband who is going to work in the forces. So therefore, she had to stop antidepressants about 1 month back. So she had a suicidal attempt. I had to again assess the suicidal ideation risk. We use sad person's score for suicidal ideation assessment, and she had 3, which needs close monitoring. And what happened? I asked. Mrs. S said her husband, she met her husband about in the time of schooling, and they had a relationship for 8 years, and they married with both parents, both of them's parents agreed for the marriage, and they married, and husband went for the job in the forces. They had 1 child about 1 year after marriage. And after that, recently, she said she was not, she thought she was not loved by the husband, and she had started a relationship with another female friend about 1 year back. And husband got caught of this relationship by a WhatsApp message. And then she was furious. He was furious, and he has hit her and told her parents. And they have decided to change the residence from her hometown, and they have shifted to Colombo. And his partner has prohibited using phone and not allowing to communicate with parents. Also, the so-called partner was taken to the police, and the husband has said police have threatened her, this partner. So this was the complexity of the issue, and there are many social taboos associated because her brothers also now are neglecting her. But still, she does the day-to-day work at home and cooks for her husband, and also takes her child to the kindergarten school and brings him back. And also, this has caused the husband to use alcohol more frequently, almost daily. And previously, she was residing in with her parents. Now she is residing in Colombo, and her husband comes home daily. So Mrs. S has a sexual orientation of bisexualism, and she had a lineation towards the lesbianism. So when I got that history, I reflect that I was not ready for that information, because it was one thing was it was a busy OPD clinic room where there was very little privacy for the patient. And also, this information, she had not really revealed herself in the psychiatric clinic. And what I did was I also tried to conceal my embarrassment. I tried her to show that I am non-judgmental. And I told her that I would take further history in a confidential environment in Madam's room, clinic room. So I took only brief history from her in the OPD room. So actually, I did now my history is almost finished. Actually, I did the same presentation as a case-based discussion during my training. And at the end, my esteemed colleague, Dr. Indlal, said, Mali, why didn't you give the phone to her? And why didn't you ask her to give a call? Then guilt is over and this uh, case is closed. So what do you think? I would like to ask your ideas. Would that be a simple resolution to this problem? Just building up a contact with her partner and ask her to apologize and relieve the guilt. Hello?
Yes, it can be a good start, isn't it?
Yeah. Any other ideas? I never thought of that until Dr. Indra told me. Okay, so this is how I try to understand Mrs. S emotions and the conflict in her. She was a bisexual with lesbian preference, and she had a guilt of her partner being accused. The exact words she used was, actually, I invited her to this relationship. I asked love from her, but at the end, she had to be blamed by the police. So that was the guilt in her mind. And there were social taboos all against her, and her brothers blaming her. Father tried. She could not communicate with parents, and husband uses more alcohol, which is more repulsive to her. And she had to shift from hometown to Colombo. All these things are negative against her, while still she wants to be a good wife to the husband. She wants to cook for her husband. She even gave up antidepressants, and she wants to be a good mother to her son. And she obeyed husband's order not to contact female partner. I think that's a very important point because she's not living in a world where there are no phones, though no communication centers. Still, she's opted not to contact her female partner, and she takes care of child well. So this is the conflict in her mind. I understood that Mrs. S is trying to be a good wife by taking all these negative things on her alone, and she is facing them. She doesn't try to disobey her husband anymore. So her husband is a person working in armed forces. What would be his feelings when he found out his wife's infidelity and the social taboos and the anger? He tried to resolve his anger by filing a police complaint and revealed everything to wife's family and made her ashamed. Then he has the wife's suicidal attempt, burden on shifting residence. And then when I further asked, she said her husband also taking treatment for depression. And also his alcohol use has increased significantly. So then we discussed the management, non-sedative antidepressants, counseling, and we plan to do a family meeting later with the husband if necessary. So in my discussion, I would like to discuss about the sexual preferences, orientation, and intersex, the LGBTIQ, the legal background, and the importance of taking a sexual history, safe sex practices, sexual education for this community, and the role of primary care physicians. So before going into more detail, we have to understand two important wordings. One is gender identity and the other is sexual orientation. So gender identity is how you think about yourself. It may be a woman, a man, or gender queer. That is, you are not sure about what your gender is. And gender expression is how you demonstrate your gender. Some may demonstrate the gender as feminine by wearing the dresses like females, and there may be masculine people and there may be androgynous people. That is, they may be female by sexual orientation, sexual identity, but they use the clothings of opposite sex. And then there is biological sex, organs, hormones, and chromosomes. There may be female, there may be a community of intersex and males. And sexual orientation is the physical, spiritual, and emotional attraction. When I inquired about my patient, she said she is having a good relationship with her husband also. Still, she prefers the relationship with the lady. So, gender is a multidimensional social and cultural construct that involves gender roles, expressions, activities, and power dynamics. The gender identity is the person's sense of being a man, woman, boy, girl, genderqueer, or non-binary. This word non-binary is a new one because in previously we thought there are only male and female, but it's not a binary thing. So gender perception is the way others interpret an individual's gender. Gender expression and gender perceptions are like expressing and percepting. A person might try to express as a male, but others might perceive him as a female. So it's not binary, definitely. There are different genders. Female, male, bigender, androgyny, and there are several. Actually, these different genders are registered in USA. In USA, there are 245 genders. There are few names here mentioned. Actually, it's very difficult to define these things for us. I mean, so many different definitions are there. For example, cisgender is a person whose gender identity aligns with the sex assigned to them at birth. Whereas transgender is someone who identifies himself with a gender other than that assigned at birth. Non-binaries identify outside the gender binary, neither man nor woman. And genderqueer should be used only for the community who identifies themselves as a queer. It's not inclusive of non-binary. That is, they say non-binary are not man or not women, whereas queers may be men or may be women, depending on the time. And gender flux is a community whose gender fluctuates in intensity. They may feel agender or maybe 100% belonging to a certain gender. Whereas gender fluid is people who don't identify as male or female, but the gender identity changes with time. Sometimes they act as males, sometimes they appear as females. So in addition, there are many pronouns used for gender-specific pronouns. Especially when you are practicing in another country, you may see that they would not like if you call them as Mr. or Mrs. such communities are very specific about the way how you name them. Instead of she, his, her, and hers, they use em, us, p, per, pers, and pers, self, like that. There are several gender pronouns also. In addition to that, I would like to touch on the topic of intersex, whereas intersex is the people born with a variation of their sexual or reproductive anatomy, such that their body does not fit to typical definitions of male or female. Actually, this is a very sensitive area because these people are born with ambiguous genitalia, and their sex is determined by either their parents or the doctor who are treating them. But when they grow up, we don't know which sex they would like to be. But already they are being maybe sent to a boys' school or girls' school. They may be dressed like males or females, but their preferences may be different. So intersex is such a condition that there are several recorrective surgeries and there are several options, hormonal options, treatment options for them to follow. So it's a biological thing. Then after discussing about gender identity, I would like to discuss the sexual orientation. Now, sexual preference is a somewhat judgmental term because preference suggests there is a choice between two choices. But when we use sexual orientation, it describes sexual attraction, behavior, and identity. And also it is not limited to two choices because there are many. There are different sexual orientations like heterosexual, homosexual, lesbian, monosexual, multisexual, pansexual, and polysexual. There are so many others. So we all know this famous term LGBTIQ. But if you consider this term, the first few things, lesbian, gay, and bisexual are sexual orientations. Whereas TIQ are for the gender identities. So lesbian is a woman who is physically, emotionally, and spiritually attracted to other women. And gay is a person physically, emotionally, and spiritually attracted to same sex. So both these are considered homosexual. And there may be bisexual person who is physically and emotionally attracted to both men and women. And those are the commonest sexual orientations. And then there are intersex, questioning, and queer. Intersex is, as I described earlier, it's an inborn variation in sexual characteristics, whereas sexual organs, chromosomes, gonads, and sexual hormones. And a gender questioning person is who is questioning their sexuality or gender identity. Whereas sexual queer is a different term in which there are sexual gender identities other than cisgender and straight. So there are several movements of this LGBTQ community, like this rainbow flag, and there are other flags also. They use the word pride flag for them, and there are several cinematic and literary encounters which depict these kind of relationships. If you can remember the best actor of the theory of everything, the actor who acted for Stephen Hawking, He acted in a transgender film called The Danish Girl. He won the Best Actor award in the Academy Awards for that role. And also there is a famous film called Brokeback Mountain, which won the Best Director and Best Screenplay and Best Film Award. And also the topic I chosen, Blue is the Warmest Color, is a famous lesbian movie. So when we consider the history of lesbianism, it originated from an island called Lesbos in Greece, ancient Greece, where there is a famous poet called Sappho, who wrote several poems about a female she loved. And if you consider even early Buddhism also has several different sexual orientations mentioned in even the Tripitaka, Vinaya Pitaka. And about the bisexualism, this word was previously used as a word to describe gender identity, especially in intersex people. But now it is used for describing a sexual orientation. It's first used in 1892 in the current meaning. Incidents in Sri Lanka. I think the first contemporary novel which discussed about lesbian and gay relationship was this Gira by Punyakanti Vijayanayaka. I think some of you may have seen the teledrama, but it doesn't contain any of that content, but it's in the book. So there was a study done involving 4,500 individuals representing all the districts of Sri Lanka, and it showed that prevalence of bisexual orientation is 8%. And also prevalence of lesbian orientation is 2% of the community. And the other things about 0.5% each, like transgender, gay, all these things. So when we consider the age distribution, we can see more prevalence of bisexual and even gay prevalence in the younger age groups. So, for example, in the age group of 45 to 65%, bisexual orientation was 5.9%, whereas in 18 to 29 years, it's 10.4%. The same pattern trend goes with other things like gay, lesbian, and transgender. So, what is the legal background? It's like in the Article 12 of the Constitution, it says all persons are equal before the law. And when they define it, no citizen shall be discriminated against on the ground of race, religion, language, caste, sex, political opinion, place of birth, or any other such grounds. But this does not include sexual orientation or gender identity. So that's where this community is raising a huge voice to include these differences to the Constitution. So also in the Penal Code, there is a section 365. Whoever voluntarily has carnal intercourse against the order of nature with any man, woman, or animal shall be punished with imprisonment of either description for a term which may extend to 10 years and fine. Using this clause, there were several cases where gay and lesbian relationships were punished previously. Now it's not the practice. Previously, it has been happened in Sri Lanka. And in the section 365A of the Penal Code, any person who in public or private commits or is a party to the commission of or procures or attempts to procure the commission by any person of any acts of gross indecency with another person shall be punished with imprisonment extended to 2 years. So this also has been interpreted previously to punish these different groups of gender identities and sexual orientations. And rights of the transgender. So if you can remember, this film depicts a story of a female who is who acts like a male and marries a female. And at the end of the film, she was being taken to the police and punished. That is according to the section 399 of the Penal Code. A person is said to cheat by personation if he or she pretends to be some other person, or representing that he or she is a person other than he or she really is. So recently, a bill by Member of Parliament Premnath C. Dolawatha was ruled that LGBTQ, these relationships are not unconstitutional. This has been considered as a victory by the LGBTIQ community. And meanwhile, most recently, International Cricket Council banned the first transgender cricketer, and she had to be retired after ICC banned transgender cricketers. This is she's a Canadian. So transgender women are said to be they are having unnecessary advantage in sports. Sex determination is part and parcel in all major sports events, but they do that by buckle smears and looking for the bar body. So these lesbian and bisexual women, as I explained in the previous study, the most prevalent is the lesbian and bisexual women. Bisexuality and lesbianism is the most prevalent in Sri Lanka. So they have many special health needs that can be addressed by GPs. But there are certain barriers that include poor knowledge among general practitioners, embarrassment, being judgmental, and also not taking proper sexual history. 90% of lesbian and bisexual women have had sex with a male. So we have to understand their sexual pattern. They are not 100% lesbian or 100% bisexual. Typically, their first sexual encounter is with a male. And we have to know about the common sexual activities also. And also, we have to understand that sexual orientation shows fluidity. For example, a bisexual woman may have a monogamous relationship with a single female or male partner. A lesbian-oriented woman may have a male partner. Now, in this case, this patient is a person with bisexual orientation with leniency towards lesbian orientation. So still she has opted to live with her husband for the rest of her life. And when we consider prevalence of sexually transmitted infections, there is higher prevalence of sexually transmitted infections among bisexual women. Prevalence of sexually transmitted infection is similar among heterosexual and lesbian women. Rates of specific sexually transmitted infections differ in these communities. And prevailing belief that lesbian women are immune to sexually transmitted infection is a myth. So commonest among lesbian as well as bisexual females is candida and bacterial vaginosis, whereas genital warts, herpes, and trichomoniasis are infrequent. Chlamydia, PID, and gonorrhea are rare, and blood-borne viruses are very rare in lesbian community especially. Rates of transmission of the highest rate of transmission is among bacterial vaginosis, HPV, and HSV. Herpes. Herpes is sexually transmissible among women. And also we have to emphasize that lesbian women have similar rate of cervical dysplasia as heterosexual women. So they need cervical screening. On the other hand, there are certain risk factors for sexually transmitted infections and also bloodborne viruses in lesbian women. Those are having had male sexual partners, early coitarchy, more sexual partners overall. But overall, lesbian and bisexual have very low risk of bloodborne virus transmission. Lesbian have the least, but bisexual have some risk of bloodborne virus transmission. In Australia, especially bisexual women have increased use of injectable drug use. Therefore, their bloodborne virus transmission rate is higher. And especially if the bisexual women have more unsafe practices pertaining to male partners, they may have a higher risk of bloodborne virus transmission. And how do we advise these people? Pap testing. It should be normal frequency as heterosexual women for both lesbian and bisexual women. And we have to advise on safe sex as well as smoking cessation. Lesbian and bisexual women smoke more than heterosexual women. And smoking creates a higher risk of cervical dysplasia. Therefore, we have to definitely advise on smoking cessation if they are smoking. This is very important if we are practicing in other countries. So the methods of safe sex. There are latex barrier methods. I don't know the availability in Sri Lanka, like dental dams. They can use condoms on sex toys and they can use latex gloves. And we have to advise them to use different hands and fingers for different orifices and washing hands and toys, and also to avoid contact during episodes of herpes. So as general practitioners, we have to gather sexual history, especially in these instances, like before a pap test, in any presentation of possible STI, when there is a new sexual partner of either gender, and when pregnancy is possible or desired. In cases of abuse, illicit drug use, and perimenopausal and even postmenopausal women, because they may be having problems related to sexual intercourse. Patients with chronic conditions, diabetes, heart diseases, COPD, they may experience sexual problems due to erectile dysfunction as well as reduced libido. So how to ensure productive communication in sexual history taking? We should avoid moral or religious judgment. And we have to avoid terms that make assumptions about sexual behavior and around orientation. For example, we cannot ask, are you monogamous? Instead, we can ask, how many partners did you have during last year? How to ensure productive communication? We may ensure shared understanding about the terminology, because these patients may use different words for their sexual organs, sexual preferences. So if we cannot understand what they say, we have to inquire and establish rapport and consent before addressing sensitive topics. We call it signposting, and it's an essential part of our communication. And we have to respect the patient's right to decline answering. We have to use the sensitive tone that normalizes the topic you are discussing, and also use neutral terms that avoid assumptions about orientation. For example, we may not use husband or wife. Instead, we can use the word partner. So there is a common model used in sexual history taking called 5P model. Whereas in the first part we ask general questions, then ask about partners, practices, past history, pregnancy plans, and pleasure. So general questions, when we starting the communication, we can ask, are you currently sexually active? What is your gender and how do you identify yourself? Or what pronouns do you prefer? This is very important in a foreign country. And we can ask about how do your partners identify? How do they identify as male, female, or another? And what are the genders of your partners? How many partners have you had in the past month, past 6 months, or even lifetime? And we can ask how satisfied are you? And has there been any change in your sexual desire or frequency? And we can ask about practices. What type of sexual activities do you participate in? And do you participate in vaginal, oral, or anal sex? And any sex-related diseases, any risk factors for HIV, blood transfusion, needle stick injuries, IV drug abuse, men having sex with men. Those things we have to consider in the past history. And we have to ask, have you ever been tested for HIV? How do you protect yourself from acquiring HIV? We can assess the patient's knowledge. Regarding the parent pregnancy plans, we can ask, are you planning to become a parent? What method do you use for contraceptive? For example, now there are many adoptive families where lesbian couples and gay couples have adopted children and they becoming parents. So that is also a possibility you have to consider when taking history from these communities. And we have to ask about the pleasure. Do you or your partner use any particular device or substance to enhance sexual pleasure? Do you ever have pain during intercourse? And do you have any difficulty in achieving orgasm, maintaining erection, any difficulty with ejaculation? And is there anything about your partner's sexual activity that you would like to change? When we inquire about the sexual health concerns, 40% of males and 50 to 90%, 98% of females had sexual health concerns, but they were reluctant to ask that from their healthcare provider. So you can understand that females are shy to ask about these problems, and they have difficulty with orgasm, inadequate lubrication, dyspareunia, body image concerns, need for information, even need for information about contraception, protection, all these things. Explicit is the updated model for addressing sexual health concerns. This model previously developed as explicit model, and later Davis and Taylor have modified it as explicit. Explicit starts with explicit permission giving. That is, you have to ask directly, not in an indirect way when you discuss about the sexual problems. And you have to provide limited information, only relevant to patient concern. Later, you can get a more detailed history assessment and identify goals of therapy, followed by intensive therapy, including special psychological therapy like CBT or acceptance and commitment therapy by a practitioner who is experienced in these kind of therapies. So in summary, a somatic presentation may be a hidden agenda. Just treating the depression may not cure a patient's illness if we cannot address the underlying true problem. Lesbian and bisexual oriented people have unmet health needs, and addressing these problems is the responsibility of the primary care physicians. So we have to practice art of acquiring sexual history, and we should use it when necessary. And by doing that, we have to be non-judgmental. It is essential. So these were my references. And I think you have gained some knowledge about a huge body of knowledge, which I think we have not, we have limited experience in talking about these things in public forums. So thank you very much. And I would like to apologize if I have caused any kind of I have hurt feelings of any kind of anyone belonging to these communities by my talk, small talk. Thank you.
Dr. Prabhath, can I ask something?
Yes, sure.
Did she mention any encounters prior to this episode with the same-sex partner?
No, this is the first time. The actually the reason for this building of this relationship was, she said she had lot of hopes about regarding her husband, and after he went to the job and when he started drinking alcohol, which she didn't like, there were certain things she was not happy about, and he was coming home about once a month, and those things she had revealed to this female partner, and gradually it has developed into an intimate partner relationship. She said she didn't have any relationship previously. This is the first one.
I know you mentioned about depression, but have you considered about borderline personality disorders?
Actually, I should have, but she had certain, she had fulfilled most of the criteria for depression, but I didn't put borderline personality, thought of borderline personality. Actually, I should have.
Thank you.
Prabhath, I have a question.
Yes.
Now, when is there any legal obligation to reveal all the components of your sex to your partner before marriage, legal marriage? Like in your case, if the patient doesn't share all his orientations with the partner, it can lead to problems in the future, like in your case. Will it come under a criminal offense or a ground for divorce, the legal side of it?
As far as I know.
Legally,
Yeah.
I mean, definitely you have to reveal, but when it comes to when you have a child and divorce and all those things, how do you approach?
Yeah. Now, think about this. We are talking about sexual orientation. Now we don't know whether we are born like heterosexual or homosexual orientations. We don't know. I mean, in certain ages, we do explore things. Actually, when she was marrying, she may be having a full heterosexual orientation. It may change with time, and it may be a intimate relationship that was built with this partner when they have met. So when she married, actually, she may not have known that she had lesbian tendencies. If I describe further, as far as I questioned her, I came to know that she was the submissive partner of the couple, and that other partner was the dominant partner. So she expected the same love that she expected from her husband, from that partner. So it's a complex situation. But this kind of things, I think you can see this slide. If you marry, if a female represents as a male and marries a female, that may be penalized in the penal code. And as far as I know, in the divorce law, there is a sentence that if a person cannot satisfy his partner, that is a cause for divorce, I think. And there is some kind of a clause. I'm not sure about that. I will find and answer you later.
Thank you, Prabhath. Just another question, if it's all right. Can I ask?
Yeah, sure.
Yeah, when it comes to subfertility,
Yes.
now sometimes one partner comes to us for the consultation, saying we've tried for a while. Then we tend not to go into detail about objectively, we have tests like seminal fluid analysis. How do you approach such a situation? Like, for example, they say we've been trying and all that. They say we tested and all the tests were normal. And but unless you get the other partner down and go into details about all the components of the sex, the time frames and the definition, they might be really complex. Have those things been talked about?
Yeah.
I don't know whether you understand what I'm trying to ask.
Yeah, I can understand. Definitely. When we are investigating into subfertility, the subfertility history taking includes these things, but we, due to our shyness and all these barriers, we usually omit these things from our history taking. And the prevalence of these kind of problems in subfertility is relatively low. Relatively low means compared to the normal population, subfertile population, when they come to seek a doctor's advice, actually they have tried. They are not learning from doctors. They are learning from their friends. They are asking from others, colleagues, all of them. They are asking what is the problem. So one thing is, in that community, the problems like what you told is not very prevalent. But still, I think we should ask about the sexual practices. Is it acceptable, Ishna?
Yes. Thank you very much. Because it's very complex. I don't know how to. What is our role? I mean, is it facilitating between the specialties, psychiatry and, or do we, like you mentioned earlier?
Yes, I think in other countries, the most viewed clinic is the transgender clinic. They have several sexual health needs. Some need hormones, some need reviews, some need pills regularly, some need contraceptive advice, and that's one of the busiest clinics in other countries. So actually, doctors don't like to go to jobs there. So therefore, these people come to tend to come to regular clinics, not going into the specific clinics assigned for them because of the queues. That's why we should be educated about all these topics, I guess.
And Dr. Prabhath, I'm trying here.
Yeah.
So that is a similar one. As you said, that ticket of entry for a person to enter into the clinic would be something else. I met one 68-year-old mother came with heaviness of chest. When we explored a son who is in US with one family, wife and one son, has gender dysphoria, and he want to change his sex into female. So he start takes hormones and those things. So
Yeah.
it was a similar experience I also had, and it was very difficult to convince a mother to accept that fact. This is sort of a common issue. Luckily, her son is now in the US, so their worry is when he comes to Sri Lanka, how to introduce him to the community.
Yeah, that's true.
Mm.
There are several social issues, social taboos related to these topics because in Sri Lanka, it's still we are reluctant and we are shy to discuss this.
Correct.
But at least as a medical community where we directly contact with the people with various needs and people of these communities, we should be at least knowledgeable about this,
Yes.
how to handle, and we should be able to discuss with them directly.
Yeah, I really appreciate your boldness to discuss this very sensitive issue in this forum. Thank you.
Thank you. Thank you.
Yes, yes.
Dr. Prabhath?
Yes. Yeah, sure.
Yeah, for the Dr. Asiana's question, the importance of sexual inability at the time of the marriage, it's a ground for the divorce. But after the marriage, if he or she develops, it's not ground for the divorce, as far as I know.
Yeah, that's true.
No,
Thank you
Priyank,
for that knowledge.
sometimes before marriage, they might know that they are bi and they will conceal it due to ethical or whatever reason, to ethical norm, and go in the normal marriage. Later they might change. Then they are depriving the partner that information. That is what I was trying to ask. If they are hiding it knowingly.
Knowingly hiding, and it
yeah.
might be social pressure. It's not, it may not be totally their fault. Their parents may be pressing them to marry.
No,
They
no, no,
can-
nothing like that. This is the case scenario. The
Yeah.
the male knows that he's bisexual.
Yes.
He's had previous partners in both sexes, but he opts to marry a male, one, like in your case,
Yes.
without revealing his other transgender component to the partner during marriage. That is the case. Is there any legal background for that? Because he didn't tell the partner about his previous orientation.
As far as I'm concerned, my knowledge, I think there is no legal background.
Yes.
But I'm not sure about the actual scenario.
Because ethically, I believe it's unfair for the partner.
Ethically unfair that Naval Giraya discusses about such a scenario. If you have read it.
I know a case like your case, the marriage was broken because one partner didn't reveal that
All right.
during marriage, and so that's why I wanted to ask that. I mean, yeah.
Any other questions?
Yes, thank you very much, Prabhat. I was listening, I was waiting for the others to ask questions. Okay, now, like your presentation, it's a huge, for that, to do this type of a presentation, you have to do a huge hours of reading. You have done it. I know you did it, and it's very wonderful and covered everything. It's not just, only the topic is totally different, and you started as the person presented with headache, and you talk about the types of headache, and then you move to depression, the criteria, and then you move to the use this sort of genders and sexuality and everything, and then the legal background in Sri Lanka. And it's so difficult. Like, it's huge. You need huge reading to do this type of a topic, and it's a eye opening for everybody, because we are talking about about the society. They do not know, they don't understand. What my question is, as medical community, do you have the adequate knowledge about this thing? That's the reason not a single document say regarding gender, the female or male only, because as according to there, how many genders in the world? So even there, how can you say I'm like male or the female? It's again then because of that, I think legally nobody can like sort of give some charges to the person, because only there are two genders they mentioned. And the other thing that we have this lot of discussion, that regarding this sexual orientation, it's not a biological thing. It's thoughts. It's suppose orientation is agricultural thought. So the thoughts may be different, but anyway, you have more sort of a likes or dislikes. So the orientation, the spiritual, or that particular lady, I know that I had a chat with that woman, and she wants to have a nice family, but she has some sort of orientation towards that particular, the female gender, that lesbian person. But even that thought may be changed like time to time. But he has a more fond of this, the orientation more towards that side. So because of that, these thoughts, of course, changing, as you all know. But for the biological, whether you are a male or a female or a transgender or whatever, it's of course, it's there. Because, Prabhath, could you please come to that particular slide that you have nicely described the gender, and there are 5 types you're talking about? Could you please go to that? The first few slides. Yes, one. Yeah, this is the one. So imagine, so gender identity is something totally different. So that is what the doctors or whoever at home who does this. And gender expression is again, nobody can change that according to their wish, their thoughts. It's that maybe the hormones, whatever the thing. So nobody can force it. And then to the rest of the things, the biological part of course, gender identity, the biological part of sex is a different thing. And it's sort of your body. I'm always telling body, mind, and social background, all these things, human being or person is that, not only just a physical body. We cannot talk about the physical body, because there are a lot of things. A human being is a lot of things. Right? Your body, the mind, and social. So all these things are describing in this slide as well. So the thing is, the thing is this first and the third one, it doesn't change a lot. Biologically, as we change, but to some extent. But those 2 and 4, it's all related to the thoughts. It may be changing. Right? So thoughts, of course, nobody can say, oh, I have this thing forever. It's all wrong. So it's changing. Because of that, I think not a single law cannot challenge because you didn't tell, because it's their thoughts. So that is the reason all these things cannot even this person. And now you all can answer the question that what Indralal, why Indralal is so silent? He raised that question. Why you didn't give a phone to that particular lady? Indralal, were you there? Hello? 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 Hello?
Yes, madam.
So you didn't heard that? Hello, Indralal?
Indralal is not here, I think, madam.
So he is but you didn't hear me.
Indralal is not here, madam.
I raised that question. Is it?
Yeah.
So now anybody can answer that question now. Because it's a thought like, okay, fine, you better give the phone call because he has some sort of the feeling that he had done a wrong thing. She had done a wrong thing. So then if you give a call to telephone to her, what will happen? What is there are 2 ways. What do you want to talk about that? What will happen? Yes, Prabhath, what do you want to say about this?
Yeah, madam, I thought she suffers for what she did, I think.
Yeah, she suffered what she did.
Yeah.
Now if you give that phone, what will happen?
Maybe there will be a new relationship.
Rebuild
Yeah.
the relationship. And then what will happen? Then, so she wants to have a good family life, but here there's sexual orientation is there, but still she wants to have a good family life. But you give some sort of a help to have this, having those orientation thoughts, just okay, well, you can do it. When what will happen? So the husband come and catch you. That's the problem. So it's a very sensitive thing, right? You cannot force, you cannot do anything. You can just discuss because, do you think that she has some sort of a worry? I'm pretty sure, but why she has this worry, that she's thinking that she had a wrong thing as well as lot of issues because of all their family and everybody, they're blaming to that lady, but only we were not judgmental. So we said, okay, fine. It's because it's a big relief to her. That per se will sort of, I don't think, she doesn't have any sort of start another sort of a relationship with her again, that particular woman. She's she's regretting, but I don't think if she has some sort of a feeling, definitely she will stop doing everything because she's nicely look after the child, nicely look after the husband. Because of that thoughts, of course, we cannot challenge, we cannot force, we cannot say it's according to our wish because it's their wish. But at least we should know their thoughts are changing. We can just help them, but don't force anything. But we can, if you give that phone, that will be end of the story, right? It will be a big issue. Luckily, we manage in that way because I don't know what will happen to her. We do not know which way it's going. Maybe she will tell, okay, she will finish everything, or else we will restart it. We do not know, but we know in our setup, Sri Lanka, as you mentioned, the transgender clinics are not happening. So where to go? What will happen to them? What will happen to the whole family? That's the problem. So we have to, because discussing that point is enough for us. Because it's a big relief to them. That's what actually now I had a chat with the director STI campaign. She wants to join this particular this thing because she was very busy and she asked me to record this. and they are trying to give some help to this transgender or the whatever the like this sexual issues, like all the things that we have mentioned. And what she also mentioned, there's not much of adequate knowledge even among the medical community. So that's a problem. So the way we look at a problem is different. At least if we have, because the day you presented this thing, only I got to know there are 200 odd like genders in the world. So we cannot say that either you are a female or a male. So we cannot take judgmental, okay, since you're a male, you should be with a woman. We cannot say, because there are a lot of things inside. So because of that, at least we have to have a very broad knowledge about these things, and please do not judgmental. So what are the instances you can ask this type of very sensitive questions? So like the sexuality, which from each and every person we cannot ask, but so we have to give some sort of a room to them to talk about their sexuality. With that only we can talk, because the community, they don't have much knowledge about those things. Even the doctors, they don't have much knowledge. So as a medical community, we should learn and we should try to give them support. I mean, that's why they want to like legalize all these things. How many people against for those things? How many people gives I don't say that is, but at least the legality should be there. They have to identify this much of genders, this much of sexual orientation, this much of things, complexity of the problem. We have to identify the complexity of the issue. So that is the thing. Even we don't have much idea of this complexity. As Ashana mentioned, it's very complex, and there are ethical, there are legal, and the social, and the spiritual. All these things are there in this particular topic. So it's very difficult to tackle. But anyway, you should have a very good knowledge. You should not be judgmental, and you should not, it's like a kind of counseling, right? In counseling, you don't give your own ideas. We ask them to come up for they should find the ways out. You just help, you just give some aids for this. That's it. So only the counseling will help, not health education will help in this matter. So for the counseling part, you should know the very good knowledge about all this. Thank you very much, Prabhath, for a very nice presentation. And I think you will upload it. Then I will send this particular thing to the relevant colleges. Okay, thank you very much. And before you wind up, I gave some sort of like options for the name for the next batch. What is the idea?
Yeah, okay, madam.
අයියෝ ඔහොමද කියන්නේ? They talk, they should talk, not you. Are there any people from that batch?
Prasad is there.
Prasad, what do you want to say? And Priyam is also there now?
Yes, madam. It's become a name with the... Hello?
Hello, yeah, I can hear you.
Yes, madam. We are now without name for 1 year. So,
Yes, that I want to give a name to you all.
so that, madam, our name become anonymous safe.
Because I gave you a name. What's that?